Okay.
All right. So I titled this chat about lung cancer screening from foundation to acceleration, because in order to, as people say, in order to go fast, sometimes you need to go slow. And building foundation towards quality and infrastructure is really important when you're talking about rolling something out on a mass population level in public health. Screening is fundamentally a public health tool in people who are asymptomatic for the disease that we're looking for. And you want to make sure that you're not doing more harm than good. I think you guys covered that. So I'm going to cover lung cancer screening from the infrastructure perspective and then move towards that acceleration component as we talk a little bit. We are very fortunate in the United States to have a screening infrastructure that is really unparalleled around the world. Many countries either don't have lung cancer screening, they're thinking about lung cancer screening, or they're doing pilot projects on lung cancer screening. And there's some really great examples that we can also learn from as they develop their pilots and implementation, how they reach people. But we fundamentally have the largest infrastructure currently for lung cancer screening in the world. And a lot of what we are doing is helping other countries to bring lung cancer screening to their population. The lessons that we learn are really helping impact not just the United States population, but populations around the world. And I like to say that not every country may be implementing lung cancer screening exactly the same way. And that's just fine, because 90 to 95% of what we're all doing has a common theme and a common agreement, even if we have different nuances is how we're doing it. So I'm going to talk about some of these structural components of lung cancer screening in the US. So in the United States, our program type, if you will, for lung cancer screening is to follow the organization of our healthcare system. We have a healthcare system that includes Medicare for our older patients, Medicaid at the state level for those who cannot afford healthcare insurance. And we have a system of healthcare that also includes structures such as the Veterans Healthcare Administration, providing healthcare to our veterans. So in many ways, we have a quilt of healthcare coverage in the US, and that quilt impacts how we can reach people for lung cancer screening. There are other countries such as the United Kingdom where they have a national healthcare system and they're rolling out lung cancer screening in a rolling basis across their country and their regions of healthcare, using a national infrastructure in something called the UK Health Check, where they offer people to come for screening who may have risk factors. So different models of healthcare drive how we roll out lung cancer screening. Our clinical programs here in the US are developed through a combination of national guidelines, such as the USPSTF, which is our primary guideline, and this quilt of coverage by the payers, which means we need to advocate to the USPSTF if we want changes and updates, to Medicare for coverage decisions, to state level offices for state Medicaid programs, and to systems of care such as the Veterans Healthcare Administration. We have many secondary guidelines for professional organizations that largely follow the USPSTF. They may have subtle nuances. They don't necessarily get updated on a regular annual basis. I think the National Comprehensive Cancer Network has the quickest, fastest updates to its guidelines, but many guidelines take a few years. And then implementation models within the US range from centralized programs to very decentralized programs. And in part that reflects the quilt and heterogeneity of our country. We have highly centralized lung cancer screenings that do programs that do everything from screen for eligibility, shared decision-making, follow the screening test and the management recommendations, to very decentralized programs where primary care physicians may primarily order the screening test, refer their patients to the screening facility to be screened, and the primary care physicians manage the test results. And the further you get away from big cities and large academic medical centers, the more there is a need for decentralized programs to reach populations that are particularly rural. The USPSTF is our national evidence-based recommendation organization for clinical preventive services. It is an independent volunteer panel of experts that focus on prevention, evidence-based medicine, and their recommendations through their rigorous review process are primarily designed for primary care physicians who are the backbone of preventative health in the United States. internal medicine, family medicine, pediatricians, behavioral health, OB-GYN, and advanced practice professionals like nurse practitioners and physician's assistants. And that is really where their sweet spot is in preventative care. And they assign each recommendation that they make a level of evidence grade from A to D. So this is our national guideline on which we base the implementation of screening. They are said to not consider cost of the preventative service when determining the grade, simply the evidence, although sometimes one wonders in the way some of the recommendations come forward. And it's important that their recommendations, no matter what their recommendation is for screening or hypertension and so on, apply only to people with no signs or symptoms of the specific disease or condition that they're evaluating. In 1998, AHRQ became the authorizing body to provide the scientific and administrative and support for the USPSTF. So with each recommendation comes a strong evidence review and plan, and AHRQ provides that. And they do provide an annual report to Congress on what the critical evidence gaps are related to preventative services and what priority areas should be looked at for further examination. And in lung cancer screening, we're only at our second positive recommendation in the last 7 to 8 years. This is the history of this infrastructure guideline that we go by in the US for lung cancer screening. The first recommendation in 1996, there was no recommendation for any lung cancer screening. Nothing had been validated. There had been some trials of X-ray and sputum cytology that did not provide a mortality benefit. They were pretty heterogeneously designed. 3 trials, about 10,000 people each in the 1970s. 2004, they revisited their guideline. They mentioned the words low-dose CT for the first time, but gave an I recommendation. There were no randomized control result trials at that time. And then in 2013, based largely on the results of the National Lung Screening Trial and some additional modeling by the CISNET team, first came forward with that recommendation to screen in individuals 55 to 80, 30-pack-year history of smoking or quit in the last 15 years. And the entire community may not exactly agree on all of these criteria, but we agree about 85 to 90% of the time of the way. A lot of people don't think the quit in the past 15 years should be included in the screening recommendation because you go from 15 years to 16 years, your lung cancer risk doesn't just precipitously drop. So there's a lot of controversy still about that recommendation. And then in 2021, again, with a grade B recommendation, they dropped the age to 50, dropped the pack years to 20, and they didn't change that 15-year quit time. And they didn't make the move towards individual risk assessment. They did address it in their paper that was published to go along with their guideline, that they did not think that there was a single risk model that people agreed to would be the penultimate risk model. And they didn't think we were ready to implement a risk model for practice. And there was hope that by reducing age and reducing pack years, they would reach populations such as African-American individuals, Black Americans, and women who may have a lower pack year history of cigarette smoking and develop cancer at an advanced stage earlier. And while it does bring more of those people into screening, it doesn't actually close the gap. It increases the screening numbers for everybody. So professional guidelines, like I mentioned from societies, they take a while to update. Societies around their 3 to 5 year time horizon, and they don't necessarily keep pace as quickly. But I will say the American Academy of Family Physicians updated their guideline within 3 weeks of the USPSTF recommendation. So that was good. Well, why is this national guideline so important? Because in the US, it drives private payer coverage. And if anything has a grade B or higher recommendation, it means that the private payers must cover it. And they're given about a 15 to 18 month window to bring that into all their insurance plans. But this was a really important part of the Affordable Care Act, is the language that links grade A and B recommendations to private insurance requirements. It does not apply to Medicare or Medicaid. So Medicare does its own national coverage decisions, which they've done twice now for lung cancer screening. And it doesn't apply to Medicaid, which is a state-based decision. Hence, advocacy at the state levels is so important. Other programs like Veterans Health Administration, Department of Defense, they follow their own process for making lung cancer screening recommendations. So we've got a guideline. We have coverage that is linked to it in many ways. We have organizations that have followed, like Medicare, and most, but not all Medicaid programs cover lung cancer screening, but not all have updated to the new criteria. One of the important things when Medicare was originally looking at lung cancer screening was, could the practice of radiology as the test performer and interpreter, if you will, do it with quality? Could we do it with low radiation exposure? That's had a lot of discussion. Could radiology practices do this? And I would say the radiology community really stepped up in terms of providing low dose protocols that are readily accessible, that have been vetted through our American Association of Physicists in Medicine that the American College of Radiology works with. So if you, no matter what CT scanner there is, you can go to this website from the AAPM and look up a protocol that is low dose for your scanner. So there's no excuse for not being able to do low dose protocols. And to date, we've seen pretty consistently low dose protocols in the ACR registry. And the other big question that was brought up is, what would we do with all these nodules? Would we be over testing, over biopsying, doing more harm than good, and exposing patients to risk? And so as CMS originally did its first coverage decision, we stepped up at the ACR and developed a structured reporting and management protocol using the initial lung RADS that was developed at Leahy Clinic by Dr. McKee, and bringing it into a structure that we know could be sustainable and adaptable into the future. So nodules get into different categories of risk by size, density, and growth pattern. And we also have a recommendation for all those other things that you see on chest CTs, besides things that could be lung cancer. Unlike screening mammography that is pretty much solely purposed for screening, with a small percent of diagnostic examinations, chest CTs have been around for decades, are done for many things: thoracic, cardiovascular, emergency related, and so on. So it has a diagnostic framework into which we added a screening test. So we're going to see a lot of other things. This is the basic framework for lung RADS, and I'll just call your attention to this category number, 0 through 4B. The higher the category, the higher the risk of lung cancer. Roughly 90% of screens are expected to be negative screens. And importantly, this is this thick line in the middle. Everything above that are considered negative, either because there's no nodules or because there's small nodules or nodules that are not growing that could be cancer, but are clinically not active cancer. They have a low likelihood, due to their small size or lack of growth, of being significant. So for example, a 4 millimeter and smaller lung nodule is considered a negative screen, whereas a 6 millimeter nodule is considered a positive screen. We know that the risk of cancer and the risk of growth goes up as nodule size increases. And the management recommendations also get more aggressive as you get into a higher cancer risk mode. So when you get into the highest category of risk, that's where multidisciplinary discussion, referral, PET scans, biopsies would be considered. Lung RADS is designed to iterate as the evidence evolved, and one good example of that is through information that's come out of screening trials has shown us that a specific type of nodule that sits on your fissures or along your pleural surfaces are simply benign intrapulmonary lymph nodes. And through large studies like the Nelson screening trial in Europe, where they followed patients who have this particular type of nodule, have found no cancers if nodules meet this definition of smooth margin, oval, lentiform, triangular shape, and a maximum diameter of under 10 millimeters. And because of that kind of research, we were able to downgrade a lot of nodules in category 3 down to category 2 negative screens. It's important to mention all those other findings that you can see on a screening CT, whether it's the aorta, the upper abdominal organs, the thyroid gland, because we will see abnormalities in there. And when the NLCRT team first met with the American Academy of Family Physicians, they weren't so worried about managing the screen detected nodules and managing the radiation dose concerns. This is what their number one concern was, is all these other things that we're now finding that have to be managed in people who are asymptomatic and generally in good enough health to undergo lung cancer screening. The ACR has been working on incidental findings for about 15 to 20 years and has 15 white papers now on incidental findings, recommendations, if you see things in the thyroid gland, the chest, the abdominal pelvic organs, what a pathway might look to, what to do next. And importantly, they're called white papers because the evidence is not there enough to call it a practice parameter or guideline. So there's a lot of expert wisdom, practice experience, and multi-specialty expertise that is built into these white papers. So important to recognize what the evidence level is, but it is a place or a framework for the management of incidental findings. And these also are updated as the research grows. And they've actually sparked research in a lot of areas. There are two specifically that are around the incidental findings that we see in the chest, which are very relevant to lung cancer screening CTs. And we pulled them all together in a one-pager or a quick reference guide because the primary care physicians and the care coordinators in lung cancer screening programs were saying, you know, we see this all the time. We don't have consistent recommendations. What can we do to help? So each of these are all published in the Journal of American College of Radiology. And this is what they look like. You start down a pathway with a finding and it goes through a framework. So if you had an incidental mediastinal mass and it was in the posterior compartment, we know those are mostly neurogenic tumors. So the recommendation is an MRI. If it's in the anterior or middle mediastinal compartment and it's a pure cyst, no further workup. But if it's not cystic, it goes down a pathway of MRI, PET, or potentially biopsy and resection. This is the framework that all of them go through. Here's an example of an anterior mediastinal mass in two different patients. It's not cystic. So we're going to go down the pathway to further evaluation. So this is just the general organization of how these guidelines, these white papers work. And this is the quick reference guide that I mentioned. It's available on the ACR website under the lung cancer screening resources, where we took all of the recommendations that came out of the incidental findings papers that could be seen on a lung cancer screening CT to help our primary care physicians and care coordinators respond when they see these. What should they do? What needs follow-up? What doesn't need follow-up? What can be left alone? It's important to know, and I think you all understand that screening is not just a test. The test is the thing that finds potential cancers, but it's all the program around that test that's really important, from smoking cessation to screen detected abnormality follow-up and returning to screening, and making sure that patients understand what that journey might look like. We think it's really important that when you get to the highest positive screens, particularly those 4B, 4X recommendations, that multidisciplinary discussion around what's best for the individual patient, their cancer risk, is really important. But we also recognize that this is not available in everywhere across the country, and creating those referral networks is really important for patients who live in rural areas. States like Montana, Utah, large distances between healthcare systems that might have this type of service. And we've seen through COVID, a lot of virtual multidisciplinary programs and collaborations being set up, and that's a good way to tackle that. We've said already that in the US, we have centralized programs that will do everything from find the nodule to manage the nodule, to biopsy the nodule, to do the surgery, the radiation oncology, very centralized structured programs. But we also have to be able to incorporate the more decentralized programs. Let's see. We also have a national quality infrastructure for lung cancer screening that came out of the first Medicare coverage decision, in which they not only said that we should follow a standardized lung nodule classification reporting system, which is what we developed in LungReds at the ACR, but in their initial coverage decision in 2015, they recommended that, or they required that you must submit data to a CMS approved registry for every screening scan that you performed in order to get for facilities to be covered by Medicare. And to that, the ACR created the Lung Cancer Screening Registry, which has a minimum set of data requirements that were required by Medicare. But we really didn't think that was enough for quality. So these are pretty basic criteria: facility, radiologist, patient, what type of CT scan are you using? Is it really a screen, making sure there's no signs or symptoms? What kind of reporting system are you using for stratifying your screens? Is smoking history covered? Is smoking cessation involved? what's your radiation dose, and was it a baseline or annual screen? So these were the minimum data elements that Medicare required. But again, that doesn't tell you how a screening practice really performs in the long term. So the ACR registry went live in 2015, and we have nearly 4 million screens entered in the registry to date through primarily electronic data uploads through vendors that collaborate with the ACR to make sure their systems can do that. But also, we still have manual data by about 1/3 of our sites in terms of entry. It covers all those CMS requirements, but we include a lot more information than that. We want to know the result of the screening test. We want to know if patients don't meet USPSTF criteria, what were the risk factors that were used to determine that somebody could undergo screening? And importantly, we want to know what the outcomes are at 12 months from that screening CT. What were additional diagnostic tests or procedures performed? Was there a biopsy? What was the tissue diagnosis? And if there is cancer, what's the stage and cell type? So we really think a quality registry needs to include not just the screening test, but the outcomes. The updated Medicare coverage decision no longer requires submission to a registry, but I'm happy to report that month over month since Medicare came out with that updated decision in February of this year, the number of screening facilities has actually increased, and we're seeing consortia want to pool their data from the registry, such as in states like Georgia and Kentucky or Colorado. And most recently, we had a request from the University of California Cancer Consortiums to be able to pool their data to see how they're functioning across the state. So we provide benchmark reports back to facilities so they can see how they're doing with a lot of measure definitions. And there's also publicly available reports on the website that are broken down by state level so that there is aggregate level annual data provided as well. We've been able to use the ACR data to look at where cancer screening is being performed, and collaborating with the National Lung Cancer Roundtable and Lior Sahar at the Cancer Society have been able to look at where people are screened and where there are gaps, whether it's in cities or in rural locations. But we've got infrastructure, that's great, but how are we doing nowadays? The American Lung Association publishes an annual State of Lung Cancer report, the last one from 2021. And this gives us a peek at how we are doing nationally. This is before the new USPSTF criteria and before the updated Medicare coverage decision. And it's pretty heterogeneous across the state. Nationally, only 5.7% of individuals believed to be eligible for screening were screened nationally under the old guidelines. Fast forward with the updated USPSTF guideline, which probably increases the number of people eligible to be screened from 8 million close to about 12 to 14 million people. And that means you can drop that percentage down pretty quickly. Massachusetts has the highest screening rate at 18%, while states like California and Wyoming have the worst screening rates at about 1%. So tremendous heterogeneity across the US. And you can pull from the ALA State of Lung Cancer report how you're doing in your state across a series of lung cancer measures, from screening to treatment, to mortality, to the risk in your population based on smoking history. And so I just pulled this graph to show you the variation that exists across the US, from the Massachusetts on the left down to Wyoming and California on the right. So this is just from our state, Michigan, 8% being screened for lung cancer. Medicaid coverage is heterogeneous, and in the ALA's report, 40 Medicaid fee-for-service programs were covering lung cancer screening. That means there are about a dozen who do not, 7 of which don't provide coverage outright, and 3 that didn't even have any information on its coverage policy. And when they dug even deeper, they found that even those that are covering lung cancer screening, most of them had not updated to the new USPSTF recommendation. So again, you've got to policy work with your states to get Medicare coverage updated and changed. Now, a peek at the first million screens in the registry about, how is this impacting, who are we screening? We looked at the first 1.2 million screens entered in the registry through 2019. The positive screen rate was about 17% on baseline screens and 13% on subsequent screens. These are higher numbers than you would expect, However, whenever you start a screening program, there is a percentage of patients coming forward for screening who are not truly asymptomatic. Your highest risk patients may also be getting referred for screening. So it's not unusual when you start screening programs, but the positive screen rates are higher than expected. The cancer diagnosis rate is lower than expected at about 0.5%. And in part, this is probably related to the challenges that facilities have when all the data is not in an integrated EMR, integrated health system, in collecting the follow-up information. Importantly, only 1 in 4 people are coming back for annual screening. So we know this is an area that needs work. Appropriateness of screening is pretty high, 87%. And when we look at some of the areas where appropriateness is not being met, less than 30 pack years and under 55 years of age, many of those people are now covered by the new USPSTF criteria. But this adherence to annual screening of 22% is really disappointing. It ranged from about 20 to 30% across all ages, smoking status, gender, race, ethnicity, and education groups, but it varied most widely by insurance status, from a low of under 10% in individuals who are uninsured to a high of 23.5% in those who are Medicaid insured. Compared to the screen eligible population, it's important to know that the screen eligible population is not the same as the similarly aged general population. Where you look where lung cancer risk populations are, they don't look the same as a slice of the regular average population of the United States. Those who are eligible for lung cancer screening are disproportionately poor, uninsured, and enrolled in Medicaid. And individuals eligible for screening are more than twice as likely to describe their health status are poor, meaning tactics that are aimed at the center of the population to engage people and educate and create awareness for screening are not going to work effectively for lung cancer screening. If we look at adult screen in practice versus those eligible for screening, we're seeing more women coming forward than you would expect. We're seeing more people in the 65 to 74-year-old population. Why? Most likely because that's when Medicare coverage pops in. And we're seeing more people who currently smoke. Not surprising, since the EMR makes it very visible who's currently smoking, but it's not so good at listing people who used to smoke. And so there's probably a relationship between the way our EHRs present data and this factor. Now, we are in this phase now where we've got great foundations, but we need to close the gaps in cancer screening and we need to accelerate. And the Cancer Moonshot and the Presence Cancer Panel really did a lot of great work on lung cancer screening that will help us accelerate, looking at improving and aligning communication, facilitating equitable access, strengthening workforce collaborations, and importantly, creating effective health IT to help with systems of care and identifying patients. And they have a brief on each of these 4 cancers for cancer screening, and the lung cancer brief is a really great read on tactics and areas of opportunity. So these are some of the tactics behind the Presence Cancer Panel report to accelerate lung cancer screening: communication campaigns for screening, supporting roundtables to help bring together organizations to drive change, community-oriented outreach and support services to promote appropriate screening and follow-up care, systems and processes that support team-based care. It's not just enough to identify somebody for screening, but through the whole screening journey, management of screening, and cancer care diagnostics and survivorship. That we need to create effective clinical decision support, both for identifying for screening and the screen detected management, things that are readily available in the IT systems that we all now work in. It's important to also recognize the last couple of years screening has taken a hit during the COVID pandemic. While this survey from the BRFA surveys from 2014 to 2020 looked at breast, cervical, and colorectal cancer and did not look at lung cancer, we can draw some similarities. The future BRF BRFSS surveys will all include lung cancer screening, so that's a positive moving forward. And in the most recent years, it's been a voluntary choice to do this. But what they looked at is lung cancer screening in the surveys between 2018 and 2020 for cervical, breast, and colorectal, and found that breast and cervical cancer screening declined by 6 and 11% respectively. Colon cancer did not decline because there was an available test, a stool test, that didn't require people to come in for healthcare to get a colonoscopy. So colon cancer testing remained relatively flat, whereas breast and cervical cancer, more aligned with lung cancer screening, did decline. So importantly, foundation to acceleration. And the National Lung Cancer Roundtable launched a national initiative through our member organizations at a meeting this summer to really start to address barriers and obstacles and tactics to overcome them so that we can reach people with lung cancer screening. And it's important, I think one of them is the way we talk about lung cancer. The face of lung cancer is different today than it was 30 to 50 years ago, because we have screening and incidental nodule programs, because we have advances in treatment from surgery, percutaneous and radiation therapy advancements to immunotherapy and biomarker-based targeted therapies. And we are seeing a slow shift from individuals who currently smoke to previously smoked to never smoke with lung cancer. And it's really important that we talk about lung cancer as a cancer that is curable, that is more survivable than ever, and that there is hope. Because if people don't have hope, they won't come forward for screening. They'll fear the screening test, not for the test itself. It's an easy test, lay on a CT scanner, take a breath in and hold it. But because of everything that comes next that makes them think that lung cancer is not survivable. The message that anyone who has lungs can get lung cancer is fundamentally important. Look around. Anyone can get lung cancer. It's important that we no longer stick to the old CDC type messaging, which was effective in reducing the number of people who smoked. It's been tagged the government super scary anti-smoking campaign, but it had the impact of creating stigma of people who smoked, who had diseases that were disfiguring. And that association of smoking with disfiguring, with poor outcomes, is something that sticks with individuals who smoke cigarettes today, recognizing that cigarette smoking is a highly addictive substance, often taken up at a young age by individuals who don't quite understand the balance of risk and harms, and has been normalized societally. So we need to end the smoking related stigma in the way we talk about lung cancer, talk about risk for lung cancer, and the way we engage in the public consciousness through patient first language. Smoking is something a person does. It does not define a person. Our histories and our medical notes shouldn't start out with a 63-year-old smoker, a 63-year-old person who smokes. Smoking is a risk factor for diseases. It does not define who they are. The CDC has thankfully worked to change some of their communication advertisements and pictures to a more positive framing. You've got this when it comes to cigarette smoking cessation activities. It's an 8 to 10 times quit attempts for many people to quit smoking. It's a marathon, not a sprint, and supporting positive change is important. And to that end, the American Cancer Society and National Lung Cancer Roundtable launched an initiative to work to end stigma in lung cancer. This is going to be a future-looking, long-standing commitment to change the dialogue and discourse, to reframe lung cancer, to improve survivorship, to create enhanced understanding and empathy, and to amplify and expand research. Some of that includes things like empathic communication skills, something we could all learn in medical school and stick with us through the duration in practice. I refer to the International Association for Lung Cancer's language guide, which uses patient-first language, person with lung cancer, not a lung cancer patient. The treatment failed the patient. The patient didn't fail treatment, which is common language in our EMRs today, in documentation. It's not a person who smokes, it's a person who smokes not a smoker, and with a lens to equity. We are continuing to use geospatial mapping and partner with state cancer consortia, health departments, and states that are looking to figure out where they need to get resources to bring lung cancer screening to populations. The state of Georgia, for example, and their cancer roundtable has looked at where their screening facilities are, and not surprising, there's where the densest population is, which is not their highest risk for lung cancer screening. So how can they bring lung cancer screening to their more population that's more rural? In the state of Ohio, through Ohio State and a grant, I believe, from Bristol Myers Squibb Foundation, they are bringing mobile CT to the Appalachian type part of Southern Ohio as a tactic, as is similarly done in states like Kentucky. In looking at geospatial mapping, we know that the majority of the population lives within 40 miles of a lung cancer screening program. And you can just see the colors. Where there's more white, there is less lung cancer screening. And these tend to be populations that are much more rural. 40 miles might seem okay if you live in the middle of Montana or driving long distances, but 40 miles doesn't work if you're in an area that doesn't have transportation, affordable transportation to reach screening centers. And having a screening facility does not mean you have access. Having an eligibility that you meet screening criteria also doesn't guarantee that you have access. Eligibility access is not the same as reaching people. And it's really important that we understand who we're trying to reach and reach them where they are in their communities, in the language that is familiar to them. I want to close with reaching people, about attitudes towards screening. We really need to understand attitudes towards screening among those who are at risk for lung cancer. And it's complex. And our invitation strategies and our communication or outreach needs to understand who we're trying to reach and what they think. And this was published in 2006 that tried to look at these attitudes towards lung cancer screening amongst socioeconomically deprived communities that have a lot of heavy smoking. And it's, in general, the population that they surveyed were supportive of screening in principle, but they were doubtful about its ability to deliver a long-term survival benefit for this generation of people who are heavy smokers, in quotation marks. Lung cancer is perceived as an uncontrollable disease. Why get screened if there's nothing, if your perception is you can't do anything about it? Fatalism, worry, and perceived lung cancer risk is particularly high among smokers compared with those who do not smoke. The perceived blame and stigma around lung cancer as a self-inflicted smoker's disease was implicated by this group interviewed as a deterrent for participating in screening. And the belief that lungs are not a treatable organ. If you have breast cancer, take out a part of your breast. You're not going to die because you took out a part of your breast tissue. Take out a part of your lung, it's considered something that it's not fathomable. How can you take out a piece of my lung and I can still survive and live? A common lay explanation that lung disease is not treatable, taking out lung cancers, leading with poor survivals, undermines the value of screening. And the messaging that we use, that you all use in reaching out to patients, to change this dialogue, to educate and help people understand through community outreach is really important. Reaching people with mental health. The group at Massachusetts General has looked at how do you improve access for people with serious mental health issues and developed a tool, an educational intervention tailored to people with serious mental health about lung cancer screening that showed that you could increase your reach to this particular population using the tactics that they developed. Other tactics that we can think of to increase lung cancer screening. Women demonstrate screening behaviors every time they come for mammograms. And we know that women in families and family units, however you define family, drive healthcare, just like they drive car purchases for their families. They drive healthcare. They get their men to healthcare. They get their loved ones to healthcare, their friends to healthcare. And so mammography is a teachable moment for people who are already coming for screening to increase their awareness about lung cancer screening, whether it's for them or it's for the people that they know and love. Mobile CT is another platform that's a tactic that is increasingly being used to bring screening to people instead of trying to get people to screening. This is an example from the Carolinas Health System that was launched in 2017, offering free lung cancer screenings to uninsured people who meet the age and smoking history criteria and who lack the access due to financial barriers, lack public transportation that makes it difficult for these individuals in rural areas to come forward screening. Their goal was to reach 1,300 screenings over 3 years. This was funded by a grant. And the results were that they screened 550 patients, short of what they expected. 20% were Black, 3% Hispanic, and 70% were rural, which was their target population. Relatively even across men and women, and a mean age of 61. They found 12 lung cancers at their initial screen, and they're continuing to do their follow-up over time as people come back from annual screening. But more and more reaching people where they are. The UK's Lung Health Check is almost exclusively based on a mobile platform going into their population. And then also to help communities, coalitions, roundtables at whatever level, we've developed at the NLCRT a state-based coalition guide to help groups form roundtables, if you will, to how do you bring people together? Who do you need to bring together? And what's your readiness level to do this? So thank you for allowing me to chat with you a little bit today. The work that you're doing will help create lung cancer survivors. It will help survivors. It will help to lower the impact of lung cancer screening through prevention, early detection, getting people who have screen detected and early detected cancers into optimal therapy in a way that is inclusive, diverse, proactive, and visionary. These are all things that I know you resonate with at ALCI, creating lung cancer survivors. Now, the last thing I'll say is if you haven't seen this, and I'm not sure I can get it to play, please look at this PSA. And I think it's important, not so much that it says you should get screened if you're at risk, because it helps frame the population of people who have high risk for lung cancer and what their life was like when they were screening as young adults, when they were smoking as young adults. What life looked like, that smoking at that time was normal in the population. Now that we have the stigma that makes smoking seem abnormal and a blame-related condition, how do we help this population of people where screening was the norm, where smoking was the norm, come forward for screening and make screening the norm in their futures?
Great. Well, thank you so much. That was incredible. It's really inspiring, and it encompassed so many different topics, aspects, and nuances of lung cancer screening and also lung cancer. We really appreciate it. So at this point in time, I'm going to have Maya, she's going to moderate our fireside chat. And please, this is open to everybody here. Either feel free to just ask a question directly, or have a question in the chat space. Just type a question in the chat space. Thank you.
So I do see a question in the chat that says, I'm a stage 4 adenocarcinoma and failed because I am not a smoker. What about the non-smokers? This is a common question that comes up about individuals who do not smoke. Currently, there are no public health recommendations or preventive service recommendations for individuals who do not smoke. There is increasing research being done, and I think that's really important, is how do we identify individuals who are at risk for lung cancer? And that could include individuals who do not smoke. Is it biomarker-based testing? Is it a blood sample? Is it something in your sputum? Is there some way we can identify an individual who does not smoke at higher risk? We're seeing in Southeast Asian countries like Taiwan, very different risk factors for lung cancer based on things like gas exposure in non-ventilated cooking environments, but also based on genetic markers that are being identified. So it's really important that before we embark on a screening program for individuals where we could do more harm than good by screening, that we understand how do we identify individuals who are at risk. And that includes individuals who do not smoke and may have other risk factors. Defining that is really important. And a lot of research needs to be done in that space.
Thank you. That was a great answer and really insightful. It's a really hard question. sometimes it's a hard question to answer. It's definitely something that we're all trying to really work on. Let's see. So we have another question from Dusty Donaldson, who, by the way, just to give her a shout out, she's doing fantastic work in her nonprofit foundation in advocacy. And so she wrote, according to the New England Journal article on the NLST, the rate of adherence to screening protocol across the 3 rounds was high, 95% in the low dose CT group and 93% in the chest X-ray group. I'm wondering why the adherence rate was so high at that time, but seems to be more challenging today.
Yeah, so NLST was a clinical research trial. We were one of the NLST sites here at the University of Michigan. In research trials, you have research coordinators, and one of their jobs is to make sure that people come back for the research protocol. And if they don't come back, it's a protocol deviation. So the drivers in a research study, the infrastructure in a research study, are often very different in practice. It's the difference between effectiveness and efficacy. You study something in science, you roll it out in real life, and now you have real life patients, real life populations. Also, NLST had a population that volunteered for a screening trial. They were motivated to be screened. They came back for screening. The population was a little more college educated than the US general population. They had a higher socioeconomic status than the general population. So the population that came forward voluntarily to be screened was also a little bit different. As we've talked a little bit about how the population at risk for lung cancer is not like the general population, more likely to be uninsured, less educated, have socioeconomic challenges. Those priority populations that are more challenging to reach in healthcare in general, that's probably part of it. But also there's a sense that, well, I had my test, maybe, I'm good to go. Didn't find anything. So maybe I don't need to come back. And then, of course, in the interim, we've also had COVID more recently. The ACR registry this year will be rolling out in November a series of quality improvement, 3 quality improvement measures with tactics. So how can you use your lung cancer screening registry data to see how you're doing? And if you're not doing well, how can you improve? One of those is lung cancer screening adherence. So the ACR dashboards will show facilities' adherence to annual screening rates. And with the quality improvement template, if you will, you can use that and say, how do I look at my data? Am I doing well or not? If I'm not doing well, here are all the things I could consider doing, the tactics that I could put in place, and then see how your data improves.
Yeah, I thought it was, Dr. Kazerooni, I thought it was really powerful, the data you showed for the first 1 million screens and the adherence rates. And thank you for showing us that, because I don't think most of the audience had ever seen that before. The real world experience. This is a little off topic, but I'm going to put down Dusty's foundation in the chat box. Please visit her. She just won the Patient Advocacy Award at World Conference on Lung Cancer, and just fantastic work that she's been doing. So, and let's see, the next question we have here is, I think, a good question actually for Maya. This is from Diane Colton. By the way, Ms. Colton, we're really appreciative of you joining our podcast and speaking about your experiences. But her question is, I am in Canada, Calgary, as a matter of fact. How can we get the information and tactics you use to bring early screening to the forefront and get it done?
So as I mentioned, the National Lung Cancer Roundtable held a summit in mid-July. We're fortunate to have Dr. Yang and Alex Potter were able to attend. It was great to see you there. And we're on the presentation stage discussing the great work of ALSI as a way to do community outreach and advocacy. So that meeting was designed, it was a 1.5-day meeting with about 100 people from all sorts of different disciplines, as well as policymaking organizations, patient advocates. Unfortunately, some of our patient advocates weren't able to come with kind of COVID things and healthcare issues happening. We are currently taking all of the tactics that were developed. So the groups were divided into 6, and they looked at different major themes and looked at barriers. So it was their first ask, what are the barriers? What are tactics was their next ask. And then ranking tactics based on resources that would be needed, time, how many people would get in for screening if we were to invest in those sorts of tactics. And so we're currently in the process of assembling those into a strategic plan for, what's like the front page, the top 4 to 6 tactics. And then what are all the others? We don't want to lose the richness of all the discussion. And then how can we engage with our member organizations and others to start developing resources and investing in addressing the barriers. Community engagement was rated very high in the original straw poll that was taken at the meeting, as well as public awareness. If you don't know as an individual that lung cancer screening even exists, if you don't know if it's right for you, I think patients also need to be huge advocates for their own healthcare. We have to obviously work on provider education, but we also have to work on just increasing general community knowledge and understanding. Breast cancer screening has its own month. People talk about it on the sidelines of soccer games and football games. People wear pink in October. Lung cancer ribbon is kind of a white, empty looking ribbon. Love your ribbons. There's my lung cancer awareness ribbon. Thank you, Chris. I see him get it in the picture there. But it needs a lot of etching, and it needs a lot of color, and it needs a lot of development to bring lung cancer screening. So as we assemble all that together, we'll definitely be sharing with you guys at ALSI and what tactics that you can take from that strategic plan that's developed to increase lung cancer screening uptake will be fantastic to see.
Thank you for that. Just real quick, I also have a ribbon right there.
Yep.
And Pierre, I know Pierre was here actually. Pierre's the founder, Pierre and Heidi are founder of the White Ribbon Project. I know they were here a little bit earlier. But yes, just put in a plug for White Ribbon Project as well to raise lung cancer awareness. We are getting really close to 3 o'clock. I want to be respectful of everybody's time, but there are really great questions still on the chat. I'll probably just summarize real quick, but I did want to point to Lauren Rosenthal. Thank you for joining us. She posted a video of early takeaway messages from the NLCRT screening summit. And so please click that to take a look, because that was a fantastic summit and really energizing and inspirational for us. So I guess in our last few minutes, I'll just summarize some of these questions. One is just a question from Raya about any advice on how to increase awareness for folks who are in lower socioeconomic status. And then also how to, I think, better identify, again, the screening for people who have never smoked. And I think those are the 2 here so far. Maybe we'll finish with those 2 questions. So.
Yeah, I think so. We've talked a little bit about for individuals who've never smoked, the evidence doesn't support it. So in that front, we need to really drive research to understand. And so investing and advocating for research dollars is really important, whether it's the NIH or foundations, to continue to invest in the research to answer the questions about individuals who have not smoked and how to identify those at a high enough risk to warrant screening, keeping in mind the benefits and harms. And the second part was, how do we reach populations that are underserved, that are priority populations, that have difficulties with access to healthcare? And we all struggle with this as healthcare systems. I've seen some amazing examples. And if you guys haven't had Sherry Erkman on your ALSI invited lectureship series before, she would be a fantastic individual to describe all of the myriad tactics that they have used through Temple University to reach populations where people have not had success before. And a lot of it is based on building foundational community trust. This is not something you do to somebody. It's not something you serve up to somebody. It's something you bring people, you bring knowledge to, you bring empowerment about, and you reach them where they live and work, where they're ready to hear the message. Pummeling people with high-level messages is probably not the best way to reach populations, but really boots on the ground. You know, we can do public service announcements, we can do awareness campaigns, but grassroots bottom up outreach, I think, is tremendously important. And that's some of the great work that you all do.
Okay, well, thank you so much again, Dr. Kazerooni. We really appreciate it. I want to thank all our terrific audience, and it's a lot of our team members from ALSI, but also a lot of our friends in patient advocacy. For example, Ms. Denise Lee, Ms.
Hey,
Diane
Ms.
Colton, Mr. Ed Cutler, our oncologist. I know Dr. Shepard was here for a little bit. I think she had to hop off, but she wanted to say hi. And Dr. Fintelman and Dr. Jacob Sands, Dr. Pierre Honda. I'm probably missing a whole bunch of other people, but I just really appreciate our entire team and our guests in this, what a wonderful opportunity and honor to listen to and learn from Dr. Kazerooni. So we'll just, give a round of applause, a Zoom round of applause, and thank you so much again. Really appreciate it.
Engage, and advocate. That's my final message.
Perfect. Great. Take care. Thank you again.
Bye-bye.